Good evening, ladies and gentlemen. On behalf of Sayville Library, my name is Jonathan Pryor. I'm the head of community outreach here at the library, and I'd like to offer you a warm welcome to Breast Health with Long Island Community Hospital, featuring Dr. Jane Testa and also Dr. David Mangiamelli with us from Long Island Community Hospital. Thank you to all of our participants who are joining us this evening. In just a second, I will share my screen and we will speak about our presenters this evening. Great. So starting with Dr. Testa, Dr. Jane Testa is a diagnostic radiology specialist with over 20 years of experience in the medical field. She graduated from Mount Sinai School of Medicine of New York University Medical School in 1994. Specializing in the field of diagnostic radiology, Dr. Testa completed her fellowship at Brigham and Women's Sagoff Center in Boston. She has worked at various breast health centers on Long Island, including Fortunato, NYU Langone Health, and Good Samaritan Hospital before joining Long Island Community Hospital in April this year. So we'd like to welcome Dr. Testa. Dr. David Mangiamelli is cancer surgeon with advanced training and experience in the area of breast surgery. He has completed a fellowship in immunotherapy for cancer at the National Institute of Health and the National Cancer Institute in Bethesda, Maryland. In addition, he has completed his fellowship of surgical oncology at the NIH-NCI surgery branch and was SSO fellow for breast surgery at Columbia Presbyterian in New York. He is currently the founding program director of our NAPBC Accredited Breast Cancer Center. All right, so welcome, Dr. Testa and Dr. Mangiamelli. And audience, bear with me just one moment while I switch screens.
Hey, Jonathan.
Thank you. Bear with me just a second.
So I'm Jane Testa. We're ready. I'm very happy to be here for Breast Cancer October month, and I'll be speaking a little bit about breast health. We'll talk a little bit about breast anatomy, breast cancer and risk factors, what increases your risk, what, if anything, you can do about it, the clinical breast exam, the dreaded clinical breast exam. And of course, I'm a breast imager, so we're going to talk about what kinds of imaging are available for our patients today. And lastly, but not least, is when you have a lump, what happens, and the kinds of biopsies that are available, and the good, the bad, the ugly of your biopsy results. Next slide. So breasts are, no two really are alike, actually. That's why radiologists like to look at your prior mammograms, because your breast is particular to you and your pattern in your mammogram is particular to you. So we can see if there are subtle changes in your breast by looking at your prior mammograms. And no two mammograms are exactly alike. It's very interesting. Next slide. We're going to talk a little bit about the anatomy of the breasts. Breasts are really glands, and they're made up of lobules, ducts, and stroma. And the next slide, please don't be crazy, is a very nice schematic of the breast. And you'll start where G is. Jonathan, can you point from the back? So these are your ribs. And then if you go forward one, that's your pectoralis muscle. That's your chest muscle. And then the pink puffy things, those are your lobules. And anterior to that, you'll see little tree trunks, and those are your ducts. Right, those are your ducts, and those carry the milk from the lobules into the nipple for your baby. Most breast cancers begin in the ducts. right here in those tree trunks that are bringing the milk into the nipple. Next slide. So what is breast cancer? Any cancer is some sort of aberrant cells. It's a cell that's gone haywire. Breast cancer occurs mostly in women, of course, and it's most commonly in the ducts, as I said. What causes breast cancer? No one knows. No one knows really what causes breast cancer. We know about what increases your risk, but we don't know why it happens. Next slide. And this is an older slide, but this talks about the top causes of death in women over 40. And heart disease, I still believe, is number one, but breast cancer is the top 5. So breast cancer is an important cause of breast cancer of death in women. And so we take it very seriously. Next slide. Risk factors. What do risk factors mean? Is anything that increases your chances of developing cancer. For example, smoking is a risk factor for developing lung cancer. So that's what your risk factor means. And next slide. Risk factors can increase your risk of developing breast cancer, your overall lifetime risk, and they include, there's a list of them there, your gender. In other words, if you're female, you have a higher risk of developing breast cancer than a male. Male breast cancers only comprise about 1% of all breast cancers. Increasing age increases your risk of breast cancer. Your personal medical history, for instance, if you've had lymphoma or Hodgkin's disease in your 20s and you've had mantle radiation, that increases your risk of breast cancer. Genetics, if your parent or you are BRCA positive, that increases your risk of breast cancer. The other increased risk is your lifelong exposure to estrogen. So in other words, if you've had a late menopause or an early menses, or you've never had a hiatus from estrogen by never having a child, or you take hormone therapy, that increases your risk. There are other risk factors: Caucasian, DES, poor lifestyle habits. The thing I wanted to point out is dense breasts. Breast density just means the amount of whiteness in your breast. And I don't think it increases your risk, but it does decrease the sensitivity of your mammography, of your mammogram, because dense breasts are white and breast cancer on your mammogram is white. So you're looking for something white on white, and it's more difficult to discern. So whether it really increases your risk or decreases your sensitivity of your mammogram, I don't know. Next slide. So there is a way of calculating your risk. Next slide, I think. Okay, so go back, Jonathan. So there's a way that your doctor and you can partner and figure out your risk factors based on all those things, all your risk factors, whether you're female, whether your parents had, when your mother had breast cancer, sister had breast cancer, you had exposure to radiation, all those risk factors can be calculated and come out with a number of percentage of your risk for your lifetime risk of breast cancer. Women who have an increased risk of breast cancer, 20 to 25%, can qualify for certain studies. and that should be paid for by insurance. For example, MRI, if you have a 20 to 25% risk of developing breast cancer in your lifetime, the American Cancer Society recommends an MRI. Next slide. So most breast cancers are not detectable in terms of, having but pain or, but there are some things that could indicate a breast cancer, like swelling of the breast, dimpling or skin puckering, breast pain, although breast pain is very uncommon in breast cancer. Nipple pain or nipple retraction, that can be a sign of breast cancer. Redness or thickening of the nipple or the skin, that can be a sign of Paget's disease, which is a particular type of cancer. Nipple discharge, and of course a lump under your arm where your lymph nodes live, that could also be a symptom or a sign of breast cancer. Next slide. So what can you do to decrease your risk factors? Lifestyle changes. I won't say become a nun, but stop smoking, limit your alcohol, exercise, keep a healthy weight, breastfeed, because that decreases your estrogen exposure over time. Try not to take postmenopausal hormones, and avoid environmental toxins. I don't know how someone can do that, but try with organic foods. Next slide. But the most important thing you can do is to adhere to early detection. And how do you do that? Next slide. You partner with your doctor, you review your medical history, you get your clinical breast exams, and you get your mammograms. Next slide. What is the clinical breast exam? During the exam, either you do yourself self breast exams. Some patients, some women drive themselves crazy doing their own breast exams. But it is a way to monitor your breast, the topography of your breast, and discover if you have any new lumps or bumps. Your healthcare practitioner tries to notice if there's differences in the size or the shape of your breasts, any rashes, any skin changes, any nipple discharge, any lumps, or any lumps under your armpit, meaning a lymph node enlargement. Next slide. If you have a lump, you bring it to the attention of your clinician, and your clinician will refer you. Now, this slide, I think, is a little bit silly because there's no way you can really tell what you're feeling a lump and you say, oh, it's smooth, it's not cancer, I don't need to get it checked out. That's not true. That's just not true. Something smooth, could be a cancer or not a cancer. What if you have very large breasts and the cancer is deep in your breast and does feel smooth, but it's a cancer? So it's not a reliable way to decide whether you need to get examined or not. If you feel a lump, you go to your doctor and you get examined. And your doctor will most likely, next slide, send you for a mammogram, because that's the best way to evaluate a lump. When you come for your mammogram, you'll meet our technologists, who are all very skilled at what they do and very caring technologists. I get my own mammogram from them and I love them. So don't be afraid to come. When you get your mammogram, they usually, if you have a lump, they'll put a little marker on it so that that alerts the radiologist, say, this is what she's feeling right here. Now, the type of mammogram you get is important also. There's something called 2D mammogram, which just is like a plain picture of your breast. And there's something called 3D or tomosynthesis. Now that is really state-of-the-art imaging for breast imaging, 3D or tomosynthesis mammogram. Now this is what we have at Long Island Community Hospital, and this is what really is state-of-the-art. And what it is instead of getting a flat picture, you get like a slice of bread. It slices through your breast, and it gives the radiologist a more detailed picture of your breast. And if you have dense breasts, the density on one side doesn't interfere with interpreting the density on the other side, the inside of your breast. So it's a very good test, and it's really state-of-the-art. Next. What other imaging tests do we have? Ultrasound. If you come in with a lump, you certainly will get a mammogram, and you certainly will get an ultrasound. And ultrasound is not X-ray. It uses sound waves to provide an image. Usually the radiologist will come in and evaluate your lump herself or himself. The other tool, imaging tool we have is MRI, also not radiation. It's a big magnet, and it spins the hydrogen atoms and actually makes a picture. Don't ask me the physics of it. That was a while ago, but it is a very powerful imaging tool we have for breast imaging. Often women who've been diagnosed with breast cancer will be sent for an MRI. Anyone whose risk factors are 20 to 25% will be sent for an MRI. All BRCA patients get sent for an MRI. So MRI is a very good tool for testing. Next slide. So you have a lump, you had these images, and now you're told you need a biopsy. So what is a biopsy? A biopsy is a sampling of the tissue. And you can be biopsied different ways. A fine needle aspiration is a tiny needle, and usually teases out some cells, or aspirates or sucks out some cells, usually like with a cyst or something that's very small, or a lymph node. You could do a fine needle aspiration. A more common biopsy is something called a core biopsy, and that could be done with ultrasound. And it's, of course, the radiologist numbs you and inserts a spring-loaded device, and it takes a core of tissue, like a yarn of tissue. And the advantage of that is that the pathologist, who is the doctor who's trained in looking at the cells and deciding, is this cancer or not cancer? It allows him or her to see the biopsy in the cells in their own architecture. So it helps them to come to a diagnosis. There's something else, it's not listed on this slide, called a stereotactic biopsy. And that is a technique where usually it uses mammography and a computer to take a biopsy. It's usually done when we see small, tiny little calcifications in the breast, or when we see architectural distortion, which can only be seen with 3D imaging, which is, again, another reason why you should be getting tomosynthesis 3D mammograms. So let me just speak a little bit about calcifications. Calcifications are what your bones are made out of. Calcifications can occur anywhere in the body, often like gallstones, those are calcifications. Kidney stones are calcifications. Hardening of the arteries, that's calcification in the wall of the vessels. And 85% of the time, calcifications in the breast are benign. Sometimes it can be an early sign of breast cancer. And so if we see calcifications in the breast, we do a stereotactic biopsy. Other types of biopsies, skin, that's usually done by a dermatologist or Dr. Mangiamelli, or surgical biopsy, obviously Dr. Mangiamelli's territory. Next slide. So what are the results? So you have your lump, you got your imaging, you got your biopsy. What happens now? What's the results? Usually we get the results in 3 or 4 days, but it seems endless to some patients, I realize that, but it usually is pretty quickly turnaround. So what is the results? The breast biopsy can come back good, bad, ugly. So good is not breast cancer, not cancer at all. It's benign. Benign requires no intervention, no further intervention. You go back to screening. You go home, you take your vacation, you be happy. So benign things are, and we list them, cysts, fat necrosis. Fat necrosis can occur in patients who've had seatbelt injuries, who've had breast reductions, who've had surgery, or just fell on their breast. You can have fat necrosis. Fibroadenomas are solid growths in the breast. They have a bimodal peak. In other words, they occur in young women and they occur in older women. Breast cancer age. So sometimes fibroadenomas do get biopsy because it's a solid mass in the breast. And the radiologist and the doctor wants to know, what is this? And prove that it's benign. Next slide. Other benign things in the breast, the good biopsy results, fibrocystic changes, that's what the breasts are. They're fibrocystic, hormonally responsive breasts. Lymph nodes, we have lymph nodes all over the body. And when we see a lymph node, sometimes it's benign, sometimes malignant, sometimes it's reactive. There's something called PASH, or pseudoangiomatous stromal hyperplasia, $1,000 pathology word for benign. It often presents as developing density in the breast. So it gets biopsy, because what is this? Why is the breast changing? And so when we biopsy, we get PASH, we breathe a sigh of relief that it's benign. And there are other fancy words here listed. Stromal fibrosis, adenosis, very common. All these are very common benign results from your biopsy. So I think we're now into the good, the bad. Next slide. Bad biopsy results show increased risk. That's what I mean by bad. It's not cancer, but it's not benign. It's what some clinicians have called pre-cancer, and often these come out because they're funny looking cells. And often you want to take out a wider area of tissue to make sure that there's not an adjacent cancer. So, and these include very commonly ADH, atypical ductal hyperplasia. And if you've had ADH removed in the past, that increases your risk a little bit of getting breast cancer. There's something called flat epithelial atypia, or FEA, that also now I think gets removed more often than not, because again, the concern is this on its way to being a cancer? Is there an adjacent cancer? So a wider area is excised to make sure that it's an increased risk factor, but not a cancer. And other things, LCI, lobular carcinoma in situ, ALH, which is a lobular hyperplasia. These are all bundled together, and they're lobular neoplasia. And then there's some grading of the lobular neoplasia, and that will denote whether it gets excised or not as well. Next slide. Other lesions that can increase your risk, it's not cancer, but it's not benign. papillomas, papillary lesions fall into like a wide category. Sometimes there's atypia associated with it and that gets removed. Sometimes the biopsy itself will show the whole papillary lesion and it's benign and then it doesn't get removed. So that's sort of the surgeon's territory and not the radiologist's territory, whether a papilloma gets removed or not. Now there's something called a phylloides tumor, which looks just like a fibroadenoma. Very similar to a fibroadenoma imaging wise, although it has some cystic spaces, but pretty similar. The thing about a phylloides tumor is that they grow. They grow very quickly. And so, you know, anything that's growing in the breast, my surgeon friends like to take out. Phylloides tumors can be rarely malignant, that they can be. So as a result, most phylloides tumors come out, excised, surgically excised, surgically removed. I have seen 3 phylloides tumors that were malignant in my career. So they're rare, they're rare. There's also something called a radial scar, which is common, and that also gets removed because the theory is that, again, there could be an adjacent cancer right next to this radial scar that can be lurking behind the scenes. And so that radial scar gets excised, surgically removed. Next. So the good, the bad, now the ugly. The ugly, malignant, meaning cancer, meaning the cells have gone haywire. They're just growing. They transgress boundaries of the anatomy, and that's what is malignant. That's a malignancy. So when we get our biopsy result back, it can be malignant, it's malignant, which means cancer, and it's either invasive, meaning it's gone beyond the confines of usually the duct, or it's non-invasive, meaning it's contained within the duct. By definition, not spread anywhere else. Next slide. So ductal carcinoma in situ. I'm sure everyone has a friend who's had DCIS, which is a non-invasive cancer. This is in the beginning, if you remember that anatomy, and Jonathan was pointing to those tree trunk type of ducts. That's where this cancer lives. And it hasn't transgressed the duct. It hasn't gone outside the duct. And this is a non-invasive cancer, and, you know, by definition, contained. By definition, not life-threatening. A pain in the neck because you need surgery and you need treatment, but not life-threatening. Then there's invasive ductal carcinoma. So the cancer has spread beyond those tree trunks and gone into the soft tissue, gone into the stroma, gone into maybe the lobules, maybe as far back as the pectoralis muscle, if you remember our diagram. So yes, invasive ductal carcinoma needs treatment, and that's the type, that is the most common type of breast cancer. 80% of breast cancers are 80 to 85% are invasive, or of invasive cancers are ductal carcinoma, and another 15 or 10 to 15% are lobular carcinoma, invasive lobular carcinoma, which starts in the lobules. Next. There are other types of malignancies, invasive mammary carcinoma, which just means that it's a mix of lobular and invasive. The pathologist looks at the cells and says, oh, there's some ductal, this is a mixed kind of cancer. And there are other types that denote a good or a bad prognosis, like inflammatory breast cancer. I think that that's one of the worst breast cancers to get. And there's other ones, mucinous, medullary, papillary, tubular carcinoma is probably one of the better cancers to get. I know my sister had a tubular carcinoma, and she's had 10-year survival rate. So she's considered cured, and it was a slow growing tumor. Next. So your tumor, your malignancy will get graded, and that just shows like how virulent this breast cancer is. You know, is it fast growing? Is it, you know, when the pathologist looks at the nuclear ratio, that, you know, it's just bursting, it's just bursting, it's just growing like wildfire. Well, that would, or is it, you know, a slow motion kind of a cancer that, you know, has been around probably for a long time and just slowly indolent cancer. So that gets graded because that is helpful for your oncologist as far as what your treatment plan would be. Also, there's something called tumor markers, which get evaluated, whether it's estrogen or progesterone positive or negative, HER2 positive, negative. These are markers that can be targeted in your treatment plan. And I'm sure Dr. Manginelli knows a lot about this. Next slide. So these are the lab tests that they'll do: hormone receptor tests, HER2 negatives. And it doesn't really take, I don't know if it takes several weeks anymore. You know, they can usually, again, the turnaround time, because we know that this is important. We want to treat our patients, you know, as urgently as possible. Our turnaround times are good. They're not, you know, we don't wait and wait and wait for results. Next slide. Your breast cancer will be staged. And again, this is something that's done by your oncologist, by your surgeon, usually on your specimen that's been excised by your surgeon. They'll look at the tumor size. They'll see whether the cancer is invasive or non-invasive. They'll see your lymph node involvement. I just want to talk a little bit about your lymph nodes, because your lymph nodes are under your armpit, in your armpit. And so your cancer, your breast drains its lymph fluid to under your armpit, under the your first lymph node. And so if you have an invasive carcinoma and you're going for surgery, you usually will get a sentinel node. A sentinel node is where the radiologist injects a little radio tracer and into your breast, and then it's draining to the first lymph node. And that first lymph node can be identified because there's a radio tracer, like a Geiger counter, and the surgeon looks for it. And it's also, they could also put some blue dye in as well. And they look for this sentinel node, and the pathologist looks at it and says, did the cancer arrive at this first node or not? It's sort of like you can't get into Manhattan unless you go through the Midtown Tunnel. So it can't, you know, if their sentinel node is taken out and it's negative, then chances are it has not spread anywhere else. Because, like I said, you can't get into New York City without going through the Midtown Tunnel. The cancer can't spread through your body without going through your lymph node first, usually. So lymph node involvement is an important area to explore and understand and know for the oncologist, so to develop a good treatment plan for you. And so, so these are the stages, and I think that's about it, Jonathan. Are there more slides? Okay, so just as my one pitch for breast cancer awareness, look at your breasts. Don't be afraid. If you see something's changed, get an exam. Come for your mammograms. Ignoring it is not going to let it go away. So please come see us. We're very friendly at the breast center. We're happy to do your mammogram. We're happy to do your imaging. And God bless.
Thank you, Dr. Testa. If it's okay, I will stop sharing my screen. We have some resource slides as well. And since we're recording, I'm just going to go through those really quickly, just so that they come up on the recording as well. All right. And are there any questions for Dr. Testa from our audience this evening? I'm going to stop sharing my screen, and we'll be able to just see everyone speaking. And if anyone would like to speak, I'll hit our participants right now with an ask to unmute option. So this way they can feel free to unmute if they would like to. And they may or may not have questions. Sometimes there isn't. Right. Everything seems fairly quiet now. Great. Dr. Testa, thank you so much for such an informative, clear presentation. Super educational. And oh my goodness, the important thing is don't wait when you find something. Go and have it checked. Thank you so much, Dr. Testa, for that presentation. We appreciate it. And we will move over to Dr. Mangiamelli at this point. And Dr. Mangiamelli, would you like to share some words?
Hi, how are you, Jonathan? I thank you, Jane, for Dr. Testa for the presentation. I mean, that is very important information. One thing that I would say, or just add from my own experience of screening women at the Breast Cancer Center, is that a lot of women are skittish about doing self-breast exams. Most commonly, they cite that they don't know what they're feeling and that their breasts are lumpy. All breasts are lumpy on the inside. And so it's not so much that you know what you're feeling, it's that when you do it once a month or whatever interval you're doing your own self-breast exam, you appreciate a change. And a change in someone's self-breast exam is very clinically significant. For me, it's more clinically significant than maybe an abnormal ultrasound, depending on the type of abnormality on the ultrasounds, but it can be more significant than an actual imaging finding sometimes. And so I agree with Dr. Testa completely. Self-breast examination is really critical in terms of self-advocacy and early detection for breast cancer. So that was a wonderful presentation by Dr. Testa. I'm going to talk a little bit more about the services that I moderate at the Breast Cancer Center and things that are available in this region for breast cancer patients. My name obviously is Dr. Mangiamelli. I'm a surgical oncologist, breast cancer surgeon. I'm program director of the Breast Cancer Center at Long Island Community Hospital. We got our first accreditation in 2014 by the American College of Surgeons. And it is a multidisciplinary approach to breast cancer. The center is, the Breast Cancer Center's epicenter is the surgical oncology office. We moderate referrals from primary care doctors, from women's imaging services, of which Dr. Testa is the program director. And we also moderate walk-in patients also. Services that patients would come for to the breast center is not just for breast cancer. We do benign disorders of the breast and chest wall, such as women who have large breasts that are seeking reductions, women who have repeated confounding findings on their mammograms and that are using multiple imaging centers. We help them coordinate their imaging strategies. We do risk assessment, and this is something I wanted to touch on as more of a component of what Dr. Testa had mentioned earlier. Most women think that their breast cancer screening starts with a mammogram at 40. And that is true for some women, but not for all women. And the only way to know what your screening regimen is based on guideline recommendations is to know what your risk is. And so primary care doctors tend not to do risk assessment, and that includes gynecologists as well. And there are computer applications that we use to estimate someone's number, like they're at a 27% chance of getting breast cancer in their life, or they're at a 12% chance of getting breast cancer in their life. And so their lifetime risk dictates how they would screen. And so, for instance, if you have, the average rate of breast cancer in the American population is approximately 1 in 8, so 12.5% lifetime chance of getting breast cancer. And so if you are found to be at 25% chance of developing breast cancer, then a mammogram annually at the age of 40 is inappropriate. It's not enough. Someone like that would have MRIs added to their mammogram annually, with physical exams biannually, twice a year. And that's according to cancer guidelines like National Cancer Institute or National Comprehensive Cancer Network, in addition to the American College of Radiology. Additionally, if someone has a first-degree relative that has breast cancer at the age of 35, screening for their daughter would start 10 years prior to the afflicted individual. And so that daughter would start at the age of 25. And so not all people are created equal, although people are comforted in knowing that they're getting their mammogram at 40, which is a good positive feeling. It's inadequate in some women. And so risk assessment is the single most important point of contention before starting your screening, because it tells you when and how you should be screening. And what the screening regimen that you use to screen can also be modified by breast density. And Dr. Testa talked about breast density as well. Breast density is a radiology finding. We tend to think of things as dense, like, a pound of feathers or a pound of lead. It's a density difference between the two. They're both a pound, but that's not actually how we refer to density in terms of women's breasts. Density is an imaging finding where the electrons are less likely to pass through the breast during the X-ray, and it produces a more white image when you're looking at the mammogram finding. And so when that's the case, you can't use contrast to find things, and it lowers the sensitivity of mammograms, just like Dr. Testa was saying. And so breast density can also change what imaging you're recommended to have in addition to your lifetime risk. And so, it's important to be risk stratified and also to know what your density is. So going back to the services that we have at the breast center. So we do risk assessment really for anybody. So you don't have to have cancer to come in for a risk assessment. As a matter of fact, even women who haven't had children and are relatively young, in their late 30s and early 40s, their risk can be high just based on their own estrogen profile. And it could meet criteria for MRIs as well. So we do risk assessment for anybody that comes and wishes to have it. We do all forms of diagnostics, mostly lending itself to Dr. Testa's clinical modalities, ultrasound, mammogram, MRI, and all of the biopsies that she does, MRI guidance, ultrasound guidance, and stereotactic, like what she was talking about earlier. We do all forms of imaging, all forms of biopsies. I also do genetic testing and genetic counseling. So even if you had nothing wrong with your breast and you had a first-degree relative with ovarian cancer, for instance, you're indicated to be tested for genetic testing. We do genetic testing for people with lots of family members with colorectal cancer and things like that. And so if somebody wishes to be genetic tested, they don't have to have breast cancer to come to the breast center. We do all forms of genetic testing and genetic counseling. From a surgical standpoint, I'm a surgical oncologist. I'm also trained in immunotherapy and oncoplastic surgery, which is basically plastic surgery as applied to cancer. So for instance, we do breast conservation through minimally invasive approaches. We use plastic specialists also for some components of reconstruction. We also do advanced reconstructions in terms of different types of flaps of reconstruction. We have a great plastics team head by Dr. Caridley. And I also do chest wall resections for certain kinds of chest wall deformities and chest wall masses. Aside from the surgery, we have an amazing cancer survivorship program that's headed through Marilyn Connerth. It's a non-for-profit that runs through education and keeps Marilyn keeps her finger on the pulse of all of the resources in Suffolk County that are usable for breast cancer patients. And so we help a lot with like transportation for patients who like radiation, for instance, that's transportation heavy. They go every day for like 4 to 5 weeks, and only for 15 minutes, but you have to transport these patients to the radiology bunker. I mean, the radiation bunker for radiation therapy. And so we assist with things like that. We have group meetings for the therapeutic benefit of psychosocial issues that are associated with breast cancer survivorship. It's a really a great bunch. And we have a full cancer registry where we keep track of our intramural cancer demographics. So basically age and types of cancers, and we watch our own metrics. So for instance, it's a quality metric to have between your first biopsy positive cancer and your first treatment. That interval of time is your treatment latency. And so having a treatment latency that's too long can raise concern. And so we always watch ourselves and how we metric with the rest of the country. We're always above average. Our last site visit through the American College of Surgeons, they looked at 30 patients at 27 metrics of quality, and we didn't have a single ding. So that was very favorable for us. It's a lot of hard work, but it really pays off in the end, because as the patients come in, you just know that you're being as patient-centric as possible. So, and we also have prospective cancer conferences for all cancer diagnoses. And so if a patient comes in and is biopsy positive for a cancer, that patient is presented at a multidisciplinary cancer conference with radiation oncologist, medical oncologist, pathologist, Dr. Testa, and even support staff is there, and the Breast Cancer Coalition. And we have a multidisciplinary conference and discussion about each cancer patient prospectively, so that we know that we're optimizing their therapy with respect to all of the disciplines, and that we're also staying within guidelines, that they're having the most modern care that they could have. So those are some of the benefits about being seen at a multidisciplinary center like that. I would also add that we have an amazing medical oncology team, radiation oncology team, and our plastics team. And we are fully, integrated into the hospital services for surgical management and medical management as well. And so it really is a seamless experience. I mean, even a woman who gets a double mastectomy with immediate reconstruction on the same day is basically, I would say 95% of the time goes home by dinner time. So, it's a very streamlined process, and it's really been a gift for me to practice here at Long Island Community Hospital. So so that's pretty much it.
Wow, quite impressive all around. Thank you so much, Dr. Mangiamelli. We appreciate that informative presentation, and how both your work and Dr. Testa's work really go hand in hand. Thank you for letting us know about the excellent care that's offered there at the hospital. Does our audience have any question for Dr. Mangiamelli? Either Andrea or Bona, do either of you have questions for Dr. Mangiamelli this evening? Feel free to unmute if you would like to.
What I would like to add to this is the whole program is under one roof, which makes for convenience. We're located at 100 Hospital Road, and Dr. Testa is at suite. Dr. Testa, what suite are you in for the women's imaging?
First floor suite.
First floor. And Dr. Mangiamelli?
I'm in suite 106. Also, I'm right across from women's imaging. We're on the same floor, same wing of the building.
Right. So it makes it very convenient. I don't want to say one-stop shopping, but it is all housed in one building. So it does for convenience.
Absolutely. Excellent. Excellent. Any other questions? Anything that anyone needs to add from our audience this evening?
Excuse me. I don't have a question, but more like a comment. And I'm sorry, I cannot turn my video on right now. But I am Bona. I'm dialing in from Chicago. I'm a residency applicant at the Long Island. So I'll be interviewing with you in a few months. So I was exploring the program, and I saw opportunities. So I said I should join, and I joined this because I work at the University of Chicago now with at the Center for Global Health, and most of our projects are actually cancer based, and my current boss does a lot of work in cancer. Her name is Fumi Olapadi, and we do a lot of genetic counseling in Nigeria, Cameroon, and in the south side of Chicago, in people of black ancestral origin. So I'm just excited to learn that Long Island Community Hospital sort of has these, similar programs, and kind of looking forward to if I match to join the community.
Well, Bona, University of Chicago is a wonderful institution. You're lucky to be there. It's a fantastic city as well. I would say that it's a good residency program that we have here in internal medicine. And I know the residents personally, and they're happy there. They have a great experience. I also have an international mission group where we go to Western Dominican Republic to capture Dominicans and Haitians who are massively undertreated for breast cancer. We do a single solitary a week of just breast cancer surgery. It's a pretty amazing effort. It's a very cool thing. But yeah, I would encourage you to apply to Long Island Community Hospital. It's a really great place to live, and it's a great place to work.
Oh yeah, fantastic. I mean, I applied already, and I have an interview coming up soon, like I said. So
good for you. Good for you. Good luck with it.
Oh, sorry, had to put something on and turn my video so that I don't look too bad. But yeah, just glad to join.
All right. Well, good luck with your application.
Thank you.
Great. Thank you, Bona. We appreciate that feedback, and we wish you the best on a very exciting journey.
Thank you so much.
Any other questions that we have from our audience this evening? All right. It seems like I think we hit the mark with both presentations. Dr. Testa and Dr. Mangiamelli, we so appreciate the time that you took out of a very stormy evening to join us and to help educate the community on the importance of imaging and also the treatment of breast cancer. Thank you so much to Carolyn Villegas and Long Island Community Hospital and the hospital as a whole for the wonderful educational resource it truly is for our community here, especially on the South Shore and in the immediate area. We so appreciate these classes that you run for us. And Carolyn, thank you always for bringing the medical staff on board. And Dr. Testa, Dr. Mangiamelli, thank you so much once again for a very productive and educational evening.
Thank you.
Jonathan, it wouldn't be possible without you. I appreciate you, and we appreciate the Sayville Library for collaborating with us and hopefully getting this education out to the community. If not tonight, then it lives on, as we say, on the Sayville Library website. Absolutely. And it will be on our website as well.
Yes, so we invite everyone to check sayvillelibrary.org for more exciting programs. We also have a Sayville Library YouTube channel. This video will wind up on our YouTube channel so that people can view this at their leisure if they were unable to make it tonight. And we will absolutely provide the link for the recording to the hospital as well. So Long Island Community Hospital can post it on their social media in addition to ours. So we make a wonderful team. Thank you so much to the hospital. And it's been our pleasure having everyone on board with us this evening at Sayville Library. I wish you a pleasant evening. Please stay out of the storm and stay dry if you can.
All right. Thank you, everyone. Take care. Thank you, guys.
Good night.
Good night.